And put HEMC in there.
Cap one.
I don't know.
Oh, come on.
Oh, that'd be a good idea. Okay.
Yeah, right. You're gonna see you putting down the dirt road and
Okay. They say what time it's due. Yeah. You just basically answer these questions.
So far.
And then it's pretty easy. That's what you
I didn't know that.
And he doesn't give you any homework, he just reads your test and answers. That's the only thing.
All right.
It's good not to have homework, but yeah. Yeah. It's only like 450 points.
Well, I thought you said you had to get
So then once the figures that out, one thing, you're like,
Okay, I'm
it's
gonna
really
go over
bad.
his report here and see what
It's him or Joe. There's no one who goes.
We'll take it.
Yeah, that's why I went to him. I just have one more question.
The nursing staff meeting.
I know, it's about.
Yep, working great. Thank you, Kelly. Bye.
So we can't be logged in under our own.
That's what you guys have to do. Yeah.
Yeah.
There's the transfer report.
Are you want to make it one or two?
Here's a printout or a copy preview of what the transfer report would look like.
Yes, here's your transfer report.
Could get rather lengthy depending on how much info you're inputting.
Shows your meds, your vitals, pulls in all of your assessments.
I save probably on copies.
What's that?
Probably save on a whole bunch of copies.
Yeah. Won't have to make copies.
But I mean, it's only 4 pages.
That's not
It's
too
got
bad.
everything we documented on a chest pain patient in here.
So you got fixed already?
Yeah, it was
Yep.
just a login. I did login in.
You just gotta log in under HCMC instead of your
Pull up a transfer form, would you?
Yep.
Get a show on those.
consent form. Do a transfer form, say print. And this is the previewer. There's your form that you all, I'm sure, recognize.
I've learned to love.
But
And
there's
this
that,
is
yeah.
where it will populate your patient, information already for you.
Is there going to be a scheduled form with that information on too that we can print out?
A scheduled form?
You know, like the scheduled for the scheduled patients that we use
To document on?
vitals and
We'll,
stuff.
we'll be
we can-
documenting in the
We'll
system
be documenting the system.
for them.
Okay, we'll show
Yep.
you today.
Yeah. We'll actually do a scheduled ER demo this afternoon, so you can see where we'll capture that documentation. No more paper. Okay, so we're gonna go ahead and open up our chart and go over the body buttons within the patient chart itself. So just starting on the actual bottom of page 21.
Sorry.
Just to review that summary, the summary tab. The summary tab is a summary tab is the summary tab. It's the same tab we see in PCS that has the same information housed in it. The summary tab is where we will go, it's taking a while to retrieve. The summary tab is where we will go to input our immunizations. The biggie, obviously, in the emergency room that we're concerned with is tetanus immunizations. So when we're assessing the patient's tetanus status, we will input that in the summary tab. This might be the problem with going through the network login as opposed to our own personal.
There.
So there you'll see our allergies, our home meds do display here. And then our immunization tab, like I mentioned, is also in the summary tab, and that's where we will input our tetanus statuses. From the summary tab down through the refresh EMR footer button, that is all the same information that we see on the PCS side. That is all the information that has been stored on our patients for that visit. It's where we're going to go to view information. We're not going to chart information in those tabs in that area. So on basically page 22 through 29 reviews that whole EMR section. I'm not going to go through all those tabs individually in detail because we've already been there, done that with PCS. A couple things I do want to point out that has been beneficial for the emergency room module. The patient care tab is where we're going to go when we want to see that the patient's snapshot of their past medical history. We know that that past medical history is incredibly long, and we found that if you go to the patient care tab and then launch into the history, you can view their past medical history real quickly.
This doesn't have any, sorry, being an open patient that has some.
You can go there to view rather quickly what the patient's past medical history is to confirm with your patient. So if a patient comes in and you want to review with them what our record is for their past medical history, if you go to this history tab, pull up all the positive responses, you could quickly go through this shorter list, hopefully, of what their current past medical history is, confirm with them this is indeed what their medical history is, confirm that there are no additions or changes, and then you could go in and launch into your past medical history and quickly recall your interventions with the information that's already been inputted. Now, if a patient has not had a past medical history completed, the positives and all response tab under the history tab is going to be grayed out. So that's your clue. This patient has never had past medical history inputted. There's nothing there. Okay? Patient care tab, history, positives to get your past medical history.
If you go over to the clinic for some visits and things, will this be on there then? It should be, correct?
Once they start
yep.
going live, yes.
Okay.
They'll
As I
start
understand,
populating.
clinic will be required to input home meds, past medical history also.
Immunizations and past medical history.
Yep. Okay. What's anything else? You can view self-explanatory. You can view vital signs inputted, eyes and nose, meds, lab, micro, and all of those individual tabs within the EMR.
Sometimes we see them come from the clinic and it'll say Norvast 5, but it won't say how often or whatever.
They're going to have to be a little
It's
better
gonna
on
have to
that
be,
side.
oh, okay.
Yes. Yes.
Okay, under that EMR section, we have the Orders tab. The Orders tab looks just like it does on the PCS side. You will see when you launch into the Orders tab, every patient from the ED should have an order set attached to it. So every time you launch into that for the first time for orders, you should see that new set's in red. What we created was a standard ER order set. So what we looked at the orders that we use most common in the emergency room and put them in as an order set. So if a particular chief complaint doesn't have its own order set, like trauma, for example, has its own order set, we attached the standing ER orders to that chief complaint. So if you click on a new set, you do have to input your ordering provider and your source, just like on PCS. And you select ER standing orders. Click Next. From here, you could go in and enter or select any orders that you wish to order for that patient. On page 31 lists the orders that are housed within the standing ER order set. If you find there are orders that you're having to consistently go in and enter individually, let us know. We can add those to our standing orders. Okay? You can also still go in and order orders individually, just like we learned with PCS, by entering a new order and then doing a search under the name in Word and entering it in. We did include some care orders within our order set too, the things that we felt like we do most often, that requires a physician order for also.
Now radiology, we won't be ordering those then?
Yeah.
Oh, I thought that was said earlier, that radiology would be in
No,
orders.
if they're coming for like repeat chest x-ray or something.
Oh, okay.
Yeah.
Scheduled.
If you click on new sets category group, show them the drop down for the ER list.
New sets, category. Here's your, all of the orders available in the ER.
Reform.
Yep. We aren't able to attach multiple order sets to one chief complaint. So an example would be if you have a patient come in with chest pain. What we attached to the chief complaint of chest pain was the ER chest pain order set. So that's what you were originally going to be prompted to when you receive a patient with chest pain. Now, if the patient ends up having an MI and you need to proceed to the acute MI with T and K's order set, then you would actually need to go in and add that order set to your patient. We were not able to attach multiple order sets to one particular chief complaint.
And if there's duplicates? If
What's
there's
that?
duplicates then?
If there's duplicates,
Uh-huh.
then you wouldn't order anything that's already been ordered.
So we'd have to make
previous.
sure we don't order that again.
Right.
And it works the same as it does on the other side. If there's a duplicate there, you'll see it, that it's already been ordered.
Another example would be like with your trauma, we attach the adult trauma standing order to a trauma chief complaint. If it ends up you have to intubate the trauma and you need the rapid sequence intubation order set, you would need to then go in and add that order set onto your patient. Any questions on those order sets? Okay. Under orders is ambulatory orders. At this time, we will not be utilizing the ambulatory orders. The ambulatory orders are going to come in play when we go live with CPOE or physician order entry in 2014. Ambulatory orders are going to be the care orders that the providers are going to order, or the orders for prescriptions on discharge when we start the whole e-prescribe process where they are going to electronically prescribe prescriptions or send referrals electronically for outpatient procedures and follow-ups with other ordering providers. So ambulatory orders we will not use at this time. It'll be about a year before we're up and running with ambulatory orders. ED visit data, I'm on page 32 of your handout. ED visit data, again, it's just a snapshot of data that we've inputted more than likely through the reception routine or the triage routine captured in the ED visit data. So if you're within a patient chart and you want to view what's been inputted, you can go to the ED visit data without having to go back to your tracker. You can do it within that patient's chart. Also, if you're already within a patient chart, you can print a ED transfer report. Again, one of those about 3 different ways to access a report. If you're within a chart, you can print it from there. ED transfer report, same thing. Work list. We all are probably very familiar now with what the work list tab sends us to. It's where we're going to go to document on our patients. Just a note on the work list with the ED nursing note. The way we're going to capture our freehand nursing notes that we document now in the emergency room is through this ED nursing note intervention. By documenting from the work list, we are able to document past documentation, so we can go in and adjust the timestamp that we're documenting something right from the work list. Patsy's going to put in another note. And then when we view the documentation, it will be viewable in a chronological order. The write note routine, which is listed a couple tabs down from your work list, will actually require you to amend a previous documentation, and it will not allow you to timestamp the time in which you performed whatever it is you're documenting on. So if you're documenting in real time, that's fine, but if you're not, you would have to manually go in and say, at 10 a.m. I did this, and then at 11 I did this, if you weren't documenting at the time. It actually requires you to amend a previous note. So we decided to stay away from that process, put our notes in chronological order, and have the ability to adjust the time at which we're documenting something through the work list intervention.
Because you can also, when you go in and document, let's say it was 10 minutes ago when I did this, I can come in here and say, 10 minutes ago, this is what happened. It's so quick and easy. The other way, it's like a 4-step process to accurately document what you're doing at the right time.
And this would just be where we normally write out it.
Right, yep. This is your longhand note, something you're not capturing somewhere else.
We are hoping to not have a whole lot of longhand notes. We're trying to capture all the required documentation that we would need to do within our assessments that we've built. But we still wanted to give you the option, if you needed to write a freehand note, an option to do that somewhere. And also the same premise with the work list. You can add an intervention. If there's something not on there that you want to document on, you can go in and add an individual intervention. With the ER, you do need to be aware so that you're searching under either a treatment or an assessment. So if we're looking to, say we want to add pericare, and we want to document we perform pericare in the emergency room, if she types in pericare, if she was under assessments, nothing would display. A treatment is essentially saying I performed something. An assessment is obviously that you're documenting a more formal assessment. So if ever you're trying to find something in the intervention dictionary to a place on your work list, if it's not showing up, toggle between treatment or assessment. It's probably there. You're maybe just not looking in the right category. Okay. Under the work list is the MAR. We will document medications from the MAR in the emergency room. We will go into a more formal MAR training. I've got a separate packet here in just a little bit. So just briefly, just to touch on the MAR, the way the MAR is going to work in the emergency room is when we pull meds out of Omnicell, the medication will then display on the MAR for us. So it's not going to be profiled, it's not going to be sent to pharmacy, it's not going to have all kinds of descriptors attached to it with special instructions or routes or any of that. It's strictly going to display as we pulled it from the MAR. And we'll get into some examples here in just a few minutes on the MAR itself. So we'll go over that.
If you take something out and return it, we'll take it back off.
No, I do not believe it will. You would have to go in and document that as probably not done, not given with a reason. Okay. Under the write note routine, or under the MAR is the write note routine, which we talked about already. Under the write note routine is the TAR. The TAR, this is the transfusion administration record. We have not had our formal training on that, so we will be learning more about the TAR. For purposes of the ED, obviously we probably won't use the TAR all that often. Maybe for an emergency transfusion. Would probably be about the only situation I could think of that we use the TAR in the ER. But we will have more formal training on the TAR itself in the next few weeks. The discharge tab is a tab we'll go to quite often. Actually, every patient that we see through the emergency room, we will need to access the discharge tab. I'm on page 37 in the handout. This is where you are going to go to discharge your patient. There's 2 tabs housed within the discharge routine, the discharge plans, and the discharge data. The first section under discharge plans is our instructions. We have built a number of diagnosis-specific instructions, and we have attached those to the chief complaints. So if you have a laceration, what should pre-populate in your drop-down selection is laceration dismissal instruction sheets.
Click it, it populates, say okay.
If for some reason there's an instruction that you want that is not displayed, that is not attached to your chief complaint, you can still go and do a lookup or go search through category. You'll see there's different category types of instructions. You can go and find your instruction that you're looking for. And we do have a list of the instructions that have been built on the very last page of your handout, page 50. Lists all the instructions that have been built. We did build a generic ED dismissal instruction sheet, so that basically takes the place of our standard one that we have now. So if you have a patient in that doesn't meet the criteria for any of those special ones we've built, you can pull in that generic ED dismissal instruction.
Yeah, and if you've chosen a chief complaint that doesn't have one pre-built for that complaint, this generic one will default just like that laceration did for the laceration. I attached the generic already to any chief complaint that didn't have something specific to it.
Can you go in there and, like, say there's something on there that you don't need and delete it off there?
No, these are just like your pre-printed forms, because these will also have to be filled out like we're doing right now. We will have to get a signature, and we'll have to get scanned back in, we don't have electronic signature.
So we'll print this and then get it
You'll
signed.
print this all out.
Yes, we have one, we'll show you.
Okay? Under the instructions is the standalone forms. We do have the ability to print some standalone forms from the discharge routine also. We have built a patient seen by provider form. So if a patient needs proof for their employer that they were in our emergency room, you can print this as part of your packet. It will automatically pull in the required information. It's essentially going to say, this patient was seen by this provider on this date at this time. So it's already there for them. The provider doesn't need to write on a script saying, I saw this patient. You can print this patient seen by form and give it to the patient to present to their employer, if you wish.
You add on there like this, cannot go back to work for 3 days.
No,
Doc's
these
gonna
forms
write on
cannot
it.
be edited.
Right.
Except by hand.
The prescriptions tab will not be used at this time. That will come in play again when the physicians start ordering their own prescriptions on discharge. Forms tab also will not be using as part of our discharge. The referrals tab we will be using. This is where you can input if a physician is requesting the patient to follow up with them or with another provider in whatever amount of time. 1 week, 10 days, 5 days, whatever. You can indicate the provider, and then you can go into the detail of the referral and actually indicate the date or the time. If it's daytime and you have the opportunity to actually make them appointment, you can indicate their appointment date and time on their discharge. It's nighttime hours, you probably won't be able to do this, but you could indicate a date that they are to follow up with their provider. You can attach a note to the appointment if you so wish. And all of that will be captured in their discharge packet, which I'll I'll hand around here in just a minute. You can add additional text if you wish to free text. It's endless. You can type all kinds of stuff in there if you wish. Anything you want to communicate to your patient. You do need to select the print language as English. If you do not have a print language selected, your packet will not print.
So
Very
we will
important.
be doing this, because a lot of times Brennan and Kramer like to do their own dismissal sheet.
We will be doing this, right?
Yep.
And printing the packet, and they can hand fill this packet out. We'll start passing it around and you'll see what they'll, and they can handwrite on there. They can tell you stuff to add in here.
The generic form will still print, so they can write whatever they want on it.
Right.
Down in the footer buttons, you'll see there's a print packet option. That's where you're going to go to print this discharge information. Part of your packet is going to include the instructions that you've indicated. It's going to include the referral. The initial page is going to list, this is what the patient has been given and been reviewed.
It also prints on the health history.
Oh, it does.
It's going to print the follow-up page. It will print the patient seen by page if you've indicated that as part of your packet. And then it will print a nice patient signature page. So there's one page that the patient will sign signifying they received all this information. So they don't have to sign on 3 different pages. There's one signature page as part of the packet. And you'll see that packet as it comes around. Okay. Any questions on that? The discharge data as part of the discharge routine, this is where you will actually go in and input your discharge date and time. You can see the ED provider in the status pre-populates, again based on information we've already put in on the patient. The clinical impressions area, that's a physician-driven area. That will be something that the provider would complete. We will not have to input anything in the clinical impressions. We can input and should input their disposition, so where are they going on discharge. We can input their condition on discharge, any discharge comments if we wish, and then here we would put in their discharge date and time. You'll see the discharge interventions down below are listed. This is going to tell you the information that needs to be charted on the patient before they can be discharged. We have hard-coded some of these interventions in the background to not allow you to discharge a patient until you've documented on the required things. Okay? Any questions on that?
I just have a quick question.
Yeah.
Is there a way that, I mean, maybe you already have it set up, is that language going to default to English in there?
We're gonna look into it, but I don't think so.
Yeah, we
I'd love
had that suggestion the other day, and I thought that was a great idea. We're kind of doubtful that it'll allow us to, but we are going to look into that.
I played around a little in it. I haven't found a place yet, but I got it on my list. I'm trying. It might be something we have to ask Amber next week.
So if you click on that ED nursing note, that's what we're missing, will it take you to that spot, or do you need to get out and go find it?
Nope, you can actually click in that square of the piece that you need to document on, and then your document down there will become highlighted, and you can launch right into that documentation from
Click it
there.
and say document. Oops, I forgot my pain assessment. It's good now. It'll tell you it's been done now.
Okay.
So it will also clue you that, oops, I forgot to document on a couple things. Oops, I called my provider at 10. He didn't come until 10:15. Yes, it was an EMC. You can populate it from here. So, yeah, it will tell you what you have to document. and then you'll click save. This is what she's saying about a hard code that it'll tell you if you haven't documented on something. Okay? Won't let you save it.
Okay, that's our discharge routine. And then the last tab in our footer buttons, or in our body buttons, under discharge is calls. And again, same thing, that's for those follow-up phone calls that we will not be using at this time. Okay? Any questions on those? Again, the last couple pages of your handout, page 47, describes the checkmark system for those lab indicators that we talked about on our status board. We wanted to make sure you saw those chief complaints. We put those on there twice. There's chief complaint list. Who's in the system?
Who's in the system?
Somebody.
Somebody knows play? No?
Maybe somebody on the floor is practicing.
Maybe.
Okay? All right, so we are going to move on to our MAR. Maybe somebody's doing that. Potentially on the floor. So you should have a separate handout stapled together. EDM training on the MAR.
Does everybody have an R? Because sometimes some of them You have an answer? You have one?
Yeah.
Everybody's got Everybody's got a mark?
Lolly, I think we're gonna be running ahead of schedule a little bit, so maybe about 15 minutes.
Okay.
Yeah.
I might need help today because if there's so many, we'll see.
Okay,
Otherwise,
that's fine.
yeah.
If not, we can wait till we're all done, I can come help you.
Well, it doesn't matter, but yeah.
Okay, on the OMAR for the emergency room. Again, medications will populate onto your MAR as you take them out of Omnicell. They will all populate as a one-time order. It's only going to display the medication as a one-time. Once you chart it, it will be in a discontinued status. So they'll all display with that little .stk med1 indication on the MAR itself. So we're going to run through some examples here of how we're going to document meds from the MAR. We will, patients will have barcodes on their wristbands. So we will be doing the same thing as on the nursing floor where we scan the patient's wristband, we scan the medication. Keep in mind there will be some situations that obviously for time's sake in the situation of the patient, we may not be able to do that if it's an emergency situation, we understand that. You will still have the ability to document without having scanned if you absolutely have to. But our preference is that we do still try to scan and confirm the patient prior to giving that medication. For purposes of training today, we aren't going to be scanning anything, so we are going to go in and indicate just by a manual documentation that we're documenting on that medication. So if you were scanning the med, you'd scan the acetaminophen that you've just pulled from the Omnicell, and then it's going to send you to your MAR and it's going to highlight in green your Tylenol that you just scanned. So we pulled 2 Tylenol, 500 or 325 milligram tablets. We're going to give both. So we're going to document on those. We pulled 2 tablets. We're going to give 2 tablets. You will see that our acetaminophen has now fallen off of our MAR, and that's because it's a discontinued medication now technically, since we said we gave it. However, it is still viewable. If you click on the discontinued box up top, you will be able to view all medications you've given even after they've been given it and are in a discontinued status. With pain medications, we will also have the ability to chart our pain reassessments from the MAR like we do in PCS. So you'll get a clock that says in 30 minutes you need to go back and reassess the patient's pain. You launch into that, it's going to launch you right into that pain assessment that we see in PCS when we document on a pain reassessment there. Any questions with that one? On the Rocephin, you will see the ceftriaxone is going to display as a 1 gram vial. That's what we removed from the Omnicell. It's not going to tell us the route in which we're giving the Rocephin. So if we need to give an IM Rocephin, we will need to attach a comment. So we're going to document it as being given. And then in the administration comment, we're going to say the route in which it was given and the location. And then if you hover over the little administration comment box, you will see that it was given IM in the right deltoid. And then to accompany the Rocephin, that would have been mixed with the xylocaine. So we pulled a vial of xylocaine out of Omnicell. What's going to display is 10 mLs as the dose administered. We all know we don't use the full vial to give the Rocephin. So you can actually adjust the dose. Say we gave 1.5 mLs. It is going to give you a prompt telling you this is smaller than what's been ordered, because all the system is going to see is that we hold a 10 milliliter vial, so that's what it's going to assume has been ordered. So we can indicate we gave 1.5 mLs, we used it to dilute with the Rocephin to give the injection. Any questions on that?
So when you pull like the Rocephin, will there be a separate place to chart for like the saline you mix it with? Or will that be all together?
The bag of saline is going to display on your MAR also.
Okay, so it'll be separately.
Yes.
Same story.
And you said only one, so what if you have to draw 2 vials of normal saline? You draw one and then shut the door and draw another one out so you can chart at both places?
Right, we will, yeah, you would.
Okay.
We're gonna go over a couple scenarios of a couple different ways to document. But yeah, for that situation, you would want each file to display separately on your MAR. Yep.
So you assume it's IV unless you document, or do you document on
You
each
give
one?
whatever's ordered.
Yeah.
You need to document it how you gave it.
Whichever it is.
Either
so
way.
You document on each one.
Right.
It's gonna populate with the stocked med in the Omnicell. If you made adjustments to that med by route or dose, you need to document it. Because your MAR is going to populate that you are getting a one-time dose of the whole thing that you pulled out of the Omni. And there'll be no route ordered or anything like that, because we don't have a pharmacist entering these. The Omnicell entered these meds for you. It doesn't know how to adjust anything.
I mean, it's gonna be self-explanatory. If you've indicated a 50 ml bag, more than likely it's to mix with the Rocephin, but it would still be good practice to indicate, just so that order's complete and clear that it was given IV.
Because
You're
someone else looking at your report, if you transfer them, they're gonna wonder what that 50 ml bag of saline was for.
You're still gonna have your written physician order. We're still gonna have orders on paper like we will with the nursing floor. The physician is still gonna need to write, or we're gonna need to write a verbal order for the meds that we administer, because taking them out of the Omnicell is not gonna prompt us to enter in the ordering provider. So you're still gonna have that paper documentation of the order that's gonna say give Rocephin 1 gram IV, to then correlate with what you documented on your MAR.
And if we have to remove them from the floor, as long as we're pushing ER patient, it will populate over to our MAR.
I don't know for sure. We need to test that one yet.
3 different meds that I have
Yeah.
on the floor.
That'll be a process we'll test with parallel run.
Yeah, we're
I would-
hoping that if you
I
take
think
it out
it
under
would.
that patient, out of the Omnicell on the floor, that it should populate that patient's MAR. We think so.
I would think too that if you took 2 out, like you took out 2 salines, it's gonna populate 2 salines.
It does, and that's
Oh,
what,
okay.
but then you can't document 2 separate administration times, and we're gonna demonstrate that
Oh,
shortly.
okay.
Don't,
What it will,
don't
what
take
will,
them out in multiples if you didn't give the whole.
yeah, what it will display on the MAR would be 20 mLs of saline.
But that's what you will, I mean, for flush, that's what you would do.
Well, if you're
so-
giving 20 all at once.
So that'd be okay then.
Yeah, if you're given 10 now and 10 in an hour, you
Right.
need 2 separate 10s.
Sure,
Right.
like for blood draw to give
But
20.
yeah, if you pull
Okay.
2, yeah, definitely, if you're gonna give 20 flush after drawing out a report, yeah, pull 2 salines, and then you'll just document as 20 mil flush. Definitely, yeah.
Well, you'd have to do the 10 mil beforehand, separate.
Yes.
Right.
Yes, don't pull 3 out and use 1 now and 2 later, you can't document it that way.
Right. Okay. Next one, the tetracaine eye drops. This is one of those situations where we felt we could have an instance where we only need to pull 1 item, but we need to document it as being given multiple times. So we're not going to go back to the Omnicell and pull out a new bottle of tetracaine every time we're going to repeat the drops. So for administration of a medication like that, we're going to go ahead and document that initial dose. So we've gotten an order to instill 2 drops into both eyes of the tetracaine. So then say 15 minutes later, the provider's working with the patient, the eyes still aren't numb enough, and we need to administer 2 more drops, but we're not going to pull a new bottle, we're going to use the bottle we already have. So in order to do that, we're going to go back into the tetracaine that we've documented on, we're going to do a full edit, and then edit. It's going to alert you that this has been a discontinued med. Are you sure you want to use this medication? Which we do. And then in the comment section, you would go in, document your time, 2 drops repeated at such and such a time with your initials. Save that. And then when you hover over your little bubble, you can see that you had repeated those drops. And then say 15 minutes later, same scenario, you need to repeat again. You can still go back in, do a full edit, and add your additional drops. Somebody asked to give us another good example of this scenario too yesterday. Do you remember what it was? It's not very often. I can't think of what it was now, but does this make sense?
Yeah, for a multi-dose.
Sometimes
Oh,
it'd be numb.
lidocaine,
It's not
yeah, that
quite
was the
enough.
one
That was it,
yesterday.
yeah.
And and they wanted to know what also happened if the doctor gave it. Same thing as, I just put by Dr. Brennan. Yeah. Because she was numb in the eye and she stuck the drops in this time.
Does that make sense?
For the moment while I'm looking at it.
What's that?
For the moment while I'm looking at it.
So like with that tetanus, say, will it automatically update on their chart
On their summary tab?
after we've given it?
I think that it should,
It's
to be honest
supposed
with
to.
you.
Okay.
Yeah. Yeah, we put an example up there of that tetanus immunization Documenting of the tetanus, you're gonna see that same screen that we see, I think we saw it with the Pneumovac when we did testing last week. There'll be certain required fields that we document on, so when you launch in to document that tetanus vaccine, you'll see where you will indicate, a lot of the fields pre-populate for you, the manufacturer, for example. You can input there the injection site that you're giving the medication, and then you do need to input the lot number and the expiration date of the immunization. One suggestion in the comment section was to document there that you gave the handout. We actually are going to check with the MAR people to see if we could actually put like a question in there saying handout given or something, just because that seems to be a piece that we do need to document on with our immunizations. Okay. Crash cart meds, this is the next one, the epinephrines. Crash cart meds was a little bit tricky. We had to kind of come up with a way to get our crash cart meds to display on our MAR. So the way we are going to handle crash cart meds is Jim is going to build a remote location called Crash Cart in our Omnicell. The medications will not be housed in Omnicell. The process will be the same of meds being housed in the crash cart. We go to pharmacy to replace the meds after we've used them. However, in order to get them to display on your MAR so that you can document on them, we're going to have you go through the Omnicell system. So you'll go to that remote location of crash cart. You'll select epinephrine, a quantity of 1. Click OK, then that epinephrine will display on your MAR so you can chart it. The only downside is, in order to display each dose, you need to select each one individually. So if you say you use 3 epinephrines, what's going to display on your MAR is 3 milligrams of epinephrine, which we know you wouldn't administer. You're going to give them at 1 milligram increments. So every time, essentially, this is going to be done after the fact. You will have more than likely already given your drugs in an emergency, and then you're going to go and get them documented onto your MAR. So it's not going to be so much of a time crunch because it's been being done afterwards. It's going to take a little bit longer. Obviously, it'd be much simpler just to say a quantity of 3, but we do want you to go in and select each one individually, so that they'll display on the MAR like this. Then you can go in and document. More than likely your administration time will need to be adjusted. You can document each one of those epi doses individually.
Then you put your 5-minute intervals out.
And that crash cart, is that the same as the Keys crash cart too? Just go under crash cart, or okay?
So what happens if the patient gets transferred out in the meantime and you don't have all this done?
Right down on
We're
a piece
still-
of paper.
We're still going to have that cardiac arrest flow sheet that we have now.
So you'll have that.
You could send that away. Copy of that with the patient. We would still want you to get the documentation at some point done and then still fax it to the receiving facility. Oh, and the other thing with the crash cart meds, you can scan the meds. So when you're doing this MAR verification after it's done, you can scan the medication box, and then it will connect that med to your MAR. So don't throw your boxes away. Keep your boxes. Like the epi boxes, the med comes in the box.
Right.
To confirm that that was the med you gave, you can scan the box with your little barcode scanner, and then it's going to attach that to your epi that's displayed on your MAR. Okay. The next medication, or it's not really a medication, but process that's in your packet is discusses the glucoscans. The glucoscans we're going to treat the same way in ED as we do the nursing floor. You will indicate through Omni that you've pulled a glucoscan, completed a glucoscan. You'll document it on the MAR, and you will document also your glucoscan result on the MAR, just like we learned with PCS.
Will that automatically go over the vital signs in, or go into vitals?
It'll be just like with PCS. Yep.
And so like, you know, the digoxin too, that's gonna, you put
It'll
in,
pull up
okay.
a pulse for you.
Yeah. The last couple of meds we wanted to show you are IV meds. With our IV medications that we pull from Omnicell, we do not have the option of documenting them as being titratable. So for the example of the lactated liquors, what's going to display on your MAR is a 1 bag of LR. It's not going to tell us the rate. So to document that, we're going to go into document, and in the administration comment, you can document the rate in which you're hanging the LR. When you save it and you hover over the box, you'll be able to see the mils per hour that you hung that bag.
Now, can you go back in there, like say the blood pressure went down, and can you go back in there and document saying that you hung?
No, but we'll
increased
show you with this next one
Okay.
where we've built that. With the nitro, that is a titratable drug, same process. When you initially hang it, you're going to document it and indicate the route or the rate at which it's being administered. So say 6 mLs or, what is it, 10 mics, I think?
Yeah.
10 mics per minute is your initial hang. And then 15 minutes later, you need to titrate that nitro. That's where that IV fluid / drip titration flow sheet is going to come in place. You're going to go to your work list and document your titrations there. We have incorporated both IV fluids and IV meds, so if you did need to document IV fluid titration, you would do it from the work list. You could even indicate your reason. Patient's hypotensive.
So when you do that each time you change your rate
Yes.
of anything.
Yeah. You can also, we added an instance type, so you could signify the location of which line or which location that particular med line is running in. So if you've got LR in the left and heparin or nitro in the right, you could signify that from that flow sheet.
And you can do all this too after patient is dismissed, right?
Yeah.
Okay.
Yep, you can change the time here,
Okay.
to what time you did it.
We did attach a protocol to the IV fluid drip titration, so you can do a quick look at all of our titratable drugs, the conversion charts. So if you get in there and can't remember what was the rate at which that, you can refer to that.
Screen?
What's that?
Can you print from that screen, like hang it on your wall?
On this,
Can you print? Yeah, you can
Yeah.
print.
print, pick your printer. I will say though, Meditex forms folder is, this is not gonna print out normal. We still have the forms folder with those drip charts if you want a paper copy. If you hit print here, all this stuff's gonna come out jumbled.
Yeah. It's weird.
It's pretty much, these forms are in here, in these protocols, they're view only. We had to do a lot of work to get forms to print correctly. I did not go to that much work. It was enough work printing all these protocols in here without trying to put them in some kind of unknown format that Meditex seems to know and nobody else does. So I wouldn't print these. You'll be very disappointed. And that's because these are too wide to print on a normal size sheet.
Any questions on that?
That care item thing came up because we put in off the list of our,
Patsy, no,
No,
you have to
this is
manually
We
Right.
were
fill.
on the MAR, and if you go to titrate IVs after you've hung that initial bag, go to your work list and here. to
It will not,
document rate
unlike
adjustments.
PCS, it will not automatically send you over there. You have to go to the work list and document your titrations.
Right. And the reason we can't use this titrate function is because these meds are not ordered by a pharmacist in the ER. So we had to find a lot of workarounds for this kind of stuff.
So
Either that or you waste time having to fax orders to the pharmacy, wait for them to put them in. We just don't have that kind of time in the ER.
but on the floor, you can use a titrate.
Yes.
Yeah.
Yes.
Yeah, this is just
Yeah,
ER.
that's the ER workaround, so you guys can get stuff in, you can titrate your drips really quickly. And the other nice thing about this work list is, let's say now I'm gonna go in here and my nitro, now I'm gonna go back down to 6, and I'm gonna decrease it 5 mics. If I hit mode, you can see your titration as you go. You can see all your rate adjustments, so you'll know what's been going on.
Okey-dokey.
Awesome.
Well, we are going to break for lunch. Salads, did you get them over? You got them over, okay.
There is one extra.
Okay.
Okay, so if
So
anybody.
you can just go up the stairs, get your salads and bring them back down.
Yep.
Remember to clock out. We'll start back up